Bismillah ar-Rahman ar-Rahim. Our lecture is about endodontic periodontal relationship. The function of the tooth depends on the health of periodontium, including gingiva, cementum, periodontal ligament, and alveolar bone. Lateral canals. They are normal anatomical landmarks in the roots of the tooth. They differ in their incidence according to their location in the root. They are present more in the apical and bifurcation region. They are a connection between the pulp and the periodontal tissue. Therefore, any infection happens in any of these tissues, the inflammation spreads to the other. Radiographically, the lesion may appear lateral to the root, which may be extended coronally to the crystal area of the attachment apparatus or to the bifurcation area. Internal tubules, interradicular lesions of the attachment apparatus may be seen from inflamed and the necrotic pulp tissue connected through the dentinal tubule. Classification of endodontic periodontal lesion. Number 1. Primary endodontic lesion. Sinus tracts originated from the apex or lateral canal of the tooth may be from along the root surface and exit or drain through the gingival sulcus. Radiographically, this drainage is seen as a radiolucency along the side of the tooth or in the bifurcation area. Clinically, pus oozing through the sulcus area with the presence of localized swelling in the gingival area. The sulcus can be probed by catapulta cone or periodontal probe to see the exit of the bone loss and source of infection. Pain is not often experienced. Vitality test should be revealed necrotic tooth or in multi-rooted teeth, one of the root canal necrotic. Treatment. Because the source is endodontic, root canal treatment is essential. Second, primary endodontic lesion with a secondary periodontal involvement. If the primary endodontic lesion is untreated, it may become involved with periodontal infection. Clinically, there is necrotic root canal with the presence of plaque and calculus. Treatment. Both endodontic and periodontal treatment is necessary to completely heal the infected area. Third, primary periodontal lesions. Periodontal disease has a progressive nature. It begins in the sulcus and migrates to the apex as deposits of the plaque and calculus produce inflammation, causing loss of surrounding alveolar bone and supporting periodontal soft tissue. This leads to the loss of the clinical attachment and formation of periodontal pockets. Osseous lesions of periodontal origin are usually associated with tooth mobility, and the affected teeth respond positively to the pulp testing. The bony lesion is usually more widespread and generalized than are lesions of endodontic origin. Radiographically, there is a lateral bone loss including a periodontal pocket. Treatment usually depends on the extent of periodontitis, and the prognosis depends exclusively on the outcome of periodontal therapy. 4. Primary periodontal lesion with secondary endodontic involvement. Periodontal disease can have an effect on the pulp through dentinal tubules, lateral canals, or both. Primary periodontal lesions with a secondary endodontic involvement differ from the primary endodontic lesion with a secondary periodontal involvement only by the sequence of disease processes. The tooth with the primary periodontal and secondary endodontic disease exhibits deep pocketing with a history of extensive periodontal disease. When the pulp is involved, the patient experiences pain and a clinical sign of the pulp disease. This situation exists when the apical progression of periodontal disease is sufficient to open and expose the pulp to the oral environment by the way of lateral canals or dentinal tubule. Radiographically, these lesions cannot be distinguished from the primary endodontic lesion with a secondary periodontal involvement. The treatment, the prognosis depends on the continuing periodontal treatment with endodontic therapy. True combined lesion, pulp, and periodontal disease may occur independently and around the same tooth. Once the endodontic and periodontal lesions join, they may be clinically indistinguishable. The prognosis of multi-rooted teeth with a combined pulpal and periodontal lesion depend on the extent of the destruction caused by the periodontal diseases component. Other pathological conditions of endo-perio relation. Number one, vertical fracture. A tooth with vertical fracture may have bone loss along the fracture line and affect the pulp and periodontal tissue. The treatment is extraction of the tooth due to poor prognosis of the condition. Number two, developmental grooves. They are present mostly in the palatal surface of the maxillary lateral incisor. This groove extends apically, therefore causing localized periodontitis and bone loss along the root surface. Clinically, they are asymptomatic until the epithelial attachment is involved by plaque, and if it reaches the groove, then periodontal infection extends rapidly. The pulp may be secondarily infected. Treatment: surgical correction of the groove and periodontal treatment. If the pulp is affected, then endodontic therapy is necessary. Number three, hemisection and root amputation. When part of the tooth is unrestorable, it is possible to extract this part and leave the rest of the tooth functional. These procedures are possible due to many reasons. A. Endodontic reason, separated instrument, root perforation, and obstructed canal. B. Periodontal reasons like furcation involvement, severe periodontal disease of one root. Number C. Restorative reason like caries destruction or erosion of the large portion of the crown and root, perforation during post-endodontic preparation or fracture. Before starting with these procedures, complete root canal treatment should be done. Hemisection means removal of half of the tooth as major root of the mandibular first molar. In severe bifurcation involvement, Separation of medial and distal roots is possible, and later on, crowning is done to each root separately. This will ensure a good access for cleaning the furcation area. Root resection means removal of one root from multi-rooted teeth without removal any of the coronal tooth structure. This may be in the maxillary molars. Thank you for your nice listening. And if you have any question, you can ask in our classroom in internet. Thank you.